So let us suppose you get a case of ulnar nerve palsy. So you say, what is your diagnosis? You say, my diagnosis is leprosy causing ulnar claw hand. Or ulnar nerve palsy. And you can say that this may be high or this may be low. The second question is, why do you say so? So you say that there are anesthetic patches, hypopigmented patches, more than 3. The nerves are thickened. And tender. And the basic nerves that you see are facial, great auricular, median radial and ulnar, lateral popliteal and posterior tibial. They may be involved, there may be sensory and motor loss in their distribution, and they may be thickened and tender. So with this you say that, why do you think that the ulnar nerve is involved? So say FCU flexor carpi ulnaris, palmar flexion, ulnar deviation, restricted wasting. Then you say FDP 3-4 involved because the claw hand is less marked. There is no flexion at the DIP joints of the third and fourth fingers, which is called as ulnar paradox. The third thing is that involvement is superficial branch of ulnar nerve, so sensory loss 1.5 fingers, the third and the fourth finger. Then you say hypothenar wasting. Abductor digiti minimi guavas test positive. Then 3-4 lumbricals, ulnar claw hand. Which is a deformity, but you can basically say that the MP flexion and PIP DIP extension is not possible because that's the function of lumbricals. Then you can say palmar dorsal intraossei, palmar intraossei involved as card test positive. Then adductor polysis involved, that means book test or Froment sign positive. You look for arthropathic joints and neurotropic ulcers as well, because that indicates leprosy. So this is how the ulnar nerve is involved. Now how would you investigate? We'll do a biopsy of the skin or the nerve, do a acid fast bacilli staining using 3% acid alcohol rather than 20%, which we use for Mycobacterium tuberculosis, and we may be able to demonstrate the lepra bacillus. and this is Ziehl-Neelsen staining. Then how would you treat? You can do nerve conduction tests also to demonstrate the paralysis or the recovery. How would you treat? Treat leprosy. That means from the standard DDS and rifampicin regime, sulfone and rifampicin regime, you stop it because that is producing a lot of antigens and producing a immunological reaction against the nerves. So stop that. Take the patient on clofazimine. To decrease the immunological damage to the nerves, you can give steroids. So that's the first thing you do. Then you splint in intrinsic plus position. To prevent contracture. You monitor for recovery, and basically you can do this up to 9 months. Then if there is residual claw hand, then you can do a surgical restoration. So you can decompress by steroids, but you can also decompress surgically, and the surgical decompression is of the canal of Cannon or the Goins canal. You open that so that the nerve is decompressed. You can also decompress the posterior tibial nerve by dividing the flexor retinaculum. And that will save anesthesia of the sole. You can also decompress the lateral popliteal nerve as it winds around the neck of the fibula. So you can do a surgical decompression, but basically shifting to clofazimine and steroids do achieve decrease in swelling, and therefore the same space becomes adequate for the nerve and the nerve is decompressed. Now what do you do in surgical restoration? So you have to restore lumbricals. And what the lumbricals are doing, basically MP flexion, metacarpophalangeal. So lumbricals can be restored by the FDS, flexor digitorum superficialis of third or second finger. This is called as Bunnell's operation. You can use the extensor carpi radialis longus or brevis. This is called as Brand's operation. And you can use other tendons also, which are not so popular, like extensor indicis and extensor digiti minimi. Then you may not restore active action of lumbricals. If you simply restore MP flexion, claw hand will be corrected, and this you can do by producing a contracture anteriorly, which can be by a capsule. You cut the anterior capsule and make it shorter, which is called as Zancoli's capsuloplasty. Or you can put in a tendon of extensor indicis. You can do what is called as a tenodesis, which is called as Fowler's operation. Or you can simply produce a skin contracture from deep to superficial. You can excise a portion of the anterior skin and produce a contracture, and that operation goes by the name of Ritchie's operation. So this is what you can basically do to restore claw hand. To restore adductor polysis, these are the 4 metacarpals. Here is the adductor polysis. The extensor carpi radialis longus inserted here, the extensor carpi radialis brevis inserted here, any of these 2 tendons. You pass through the third interosseous space. You pass through this. Pass through this, go parallel to the adductor polysis and insert it here. So extensor carpi radialis longus or brevis to adductor pollicis. So this is the management of a short case of ulnar paralysis because of leprosy.